Alterations of pulmonary function in children. Upper airway disorders in children can lead to serious breathing problems due to the small size and softness of pediatric airways. These conditions may result from infections, trauma, or inhaled foreign objects. Obstructive sleep apnea is also a common cause of upper airway obstruction during sleep. Prompt recognition and treatment of upper airway compromise are critical in children to prevent respiratory distress. Viral croup, also called acute laryngotracheal bronchitis, is a common illness in children between 6 months and 5 years of age. It is usually caused by the parainfluenza virus and results in inflammation and swelling just below the vocal cords. The illness often begins with symptoms of a cold but progresses to a harsh, barking cough, hoarse voice, and inspiratory stridor. Most cases resolve within 1 to 2 days without complications. Spasmodic croup is a recurrent form of croup that occurs without signs of infection. It typically appears suddenly at night and resolves just as quickly. Though the symptoms are similar to those of viral croup, including barking cough and stridor, there are no associated cold-like symptoms. It is thought to have an allergic or familial component. Bacterial tracheitis, sometimes referred to as pseudomembranous croup, is a serious and potentially life-threatening upper airway infection. It is most often caused by bacteria such as Staphylococcus aureus or Haemophilus influenzae. Children with this condition may require endotracheal intubation and antibiotic therapy. Unlike viral croup, bacterial tracheitis typically has a more rapid and severe course. This slide likely reinforces the need to distinguish between bacterial and viral causes of upper airway infection. Bacterial infections tend to be more aggressive and may not respond to the typical supportive treatment used for viral croup. Airway management becomes critical as swelling progresses. Hospitalization is often necessary. Acute epiglottitis is a rapidly progressing and life-threatening infection that causes severe inflammation of the epiglottis and surrounding tissues. It was once commonly caused by Haemophilus influenzae type B, but vaccination has greatly reduced its incidence. Children present with high fever, difficulty breathing, drooling, and a muffled voice. Because airway obstruction can occur suddenly, throat examination should be avoided, and immediate antibiotic treatment is initiated. Tonsillitis in children may occur as a result of bacterial or viral infections, including Epstein-Barr virus. In recent years, Group E Streptococcus and methicillin-resistant Staphylococcus aureus have become more frequent causes. In severe cases, the infection can form abscesses that block the airway. These children may need antibiotics, drainage procedures, or even surgical intervention. Aspiration of foreign objects is most common in children between 1 and 4 years of age. Symptoms can include sudden coughing, choking, wheezing, or gagging. The severity of symptoms depends on the size and location of the object. Removal by bronchoscopy is typically required to prevent long-term complications. Obstructive sleep apnea in children is caused by intermittent or partial blockage of the upper airway during sleep. It may result from enlarged tonsils or adenoids, airway inflammation, or neuromuscular problems. Affected children may snore, have labored breathing during sleep, or wake frequently. This condition can interfere with rest and development if not properly treated. During sleep, children with obstructive sleep apnea may exhibit snoring, sweating, or restlessness. Daytime symptoms can include sleepiness, difficulty concentrating, and poor academic performance. Treatment often involves removing the tonsils and adenoids or using continuous positive airway pressure to keep the airway open. Early treatment helps restore healthy sleep patterns and prevent long-term complications. Disorders of the lower airways are a leading cause of illness in infants. especially in the first year of life. These include conditions such as surfactant deficiency, bronchopulmonary dysplasia, respiratory infections, asthma, and cystic fibrosis. Infants are especially vulnerable due to their small airway diameter, immature immune response, and limited respiratory reserve. Prompt recognition and supportive care are critical for positive outcomes. Surfactant Deficiency Disorder, also known as respiratory distress syndrome of the newborn, is most common in premature infants. It results from immature lungs that lack sufficient surfactant, the substance that helps keep alveoli open. Without it, the lungs collapse easily, causing widespread atelectasis and impaired oxygen exchange. The condition leads to significant hypoxemia and often requires respiratory support at birth. In this condition, the lack of surfactant also contributes to persistent pulmonary hypertension, as blood is shunted away from the underinflated lungs. Clinical signs include rapid breathing, grunting on expiration, flaring of the nostrils, chest retractions, and a bluish skin tone called cyanosis. These symptoms often begin shortly after birth and reflect both poor oxygenation and increased effort to breathe. Early treatment with supplemental oxygen and surfactant therapy can be life-saving. This slide likely emphasizes the progression and management of surfactant deficiency disorder. Advances in neonatal care, including antenatal corticosteroids and exogenous surfactant replacement, have significantly reduced mortality. However, long-term complications may still develop, especially in extremely premature infants. These infants require close monitoring for potential chronic lung disease. Bronchopulmonary dysplasia is a chronic lung condition that affects infants who have required prolonged oxygen therapy or mechanical ventilation. It is characterized by arrested lung development, resulting in fewer and larger alveoli with less surface area for gas exchange. The condition stems from a combination of prematurity, inflammation, and injury to the developing lungs. This disease has become less common due to better neonatal care and preventative strategies. Children with bronchopulmonary dysplasia often experience labored breathing, low oxygen levels, and high carbon dioxide levels. Additional features include airway inflammation, bronchospasm, mucus plugging, and pulmonary hypertension. Treatment is supportive and may involve oxygen therapy, bronchodilators, and careful nutritional management. Long-term respiratory and developmental follow-up is usually necessary. Bronchiolitis is a common viral infection of the small airways, almost exclusively affecting infants and toddlers. The most frequent cause is respiratory syncytial virus, or RSV, especially during the winter months. Early symptoms include runny nose, low-grade fever, and decreased appetite, followed by tight cough, wheezing, and rapid breathing. Severe cases may require hospitalization for oxygen and hydration. Viral pneumonia in children is most often caused by respiratory syncytial virus, but other culprits include parainfluenza, influenza, rhinovirus, and adenovirus. The infection affects the terminal airways and alveoli, resulting in cough and difficulty breathing. Fever may be absent, and the white blood cell count is often normal, which can make diagnosis challenging. Supportive care is usually sufficient for recovery. Bacterial pneumonia is more severe and is most commonly caused by Streptococcus pneumoniae, although Staphylococcus aureus and atypical bacteria may also be involved. It often follows a viral illness and presents with fever, chills, productive cough, and shortness of breath. Crackles or reduced breath sounds may be heard on exam. Vaccination against pneumococcus and influenza has greatly reduced the incidence of this infection in children. Atypical pneumonia in children is most commonly caused by Mycoplasma pneumoniae or Chlamydophila pneumoniae. These infections typically affect school-aged children and young adults and differ from classic bacterial pneumonias. Symptoms develop slowly and may resemble a mild upper respiratory infection, with low-grade fever and a persistent cough. Most cases are self-limiting and respond well to outpatient treatment. Aspiration pneumonitis occurs when a foreign substance, such as food, saliva, stomach contents, or environmental chemicals, is inhaled into the lungs. The condition leads to inflammation, infection, and sometimes permanent lung damage, depending on the amount and acidity of the aspirate. It is a leading cause of death in children with neurologic impairment. Prevention and rapid intervention are key to avoiding respiratory failure. Asthma is the most common chronic disease of childhood, characterized by bronchial hyperresponsiveness and reversible airway obstruction. It typically arises from a combination of genetic predisposition and environmental exposure to allergens or irritants. During an asthma attack, the airways narrow, mucus production increases, and inflammation worsens the obstruction. Proper management is crucial to prevent hospitalization and improve quality of life. Common symptoms of asthma in children include a persistent cough, wheezing, rapid breathing, nasal flaring, and the use of accessory muscles to breathe. Symptoms are often triggered by allergens, exercise, cold air, or respiratory infections. Treatment focuses on long-term control through inhaled corticosteroids and quick-relief bronchodilators during acute episodes. Education and asthma action plans are vital for families managing this condition. Acute respiratory distress syndrome, or ARDS, is a life-threatening condition caused by widespread inflammation in the lungs. It can result from direct injury, such as pneumonia, smoke inhalation, or near drowning, or from systemic insults like sepsis or trauma. Inflammatory mediators damage the alveolar capillary membrane, leading to fluid buildup in the alveoli and impaired oxygen exchange. The resulting pulmonary edema is not caused by heart failure, but by injury to the lung itself. Acute respiratory distress syndrome usually develops within 7 days of the triggering event and presents with increasing respiratory difficulty, low oxygen levels, and infiltrates visible on chest imaging. Children may hyperventilate at first, but eventually experience respiratory fatigue and failure. Treatment requires mechanical ventilation and comprehensive supportive care. Outcomes vary depending on the child's condition and the severity of lung injury. Cystic fibrosis is an inherited disease that affects the lungs, digestive system, and reproductive organs. It is caused by a mutation in a gene that disrupts the movement of salt and water in and out of cells, leading to thick, sticky mucus. In the lungs, this mucus clogs airways and traps bacteria, resulting in chronic infections and inflammation. Over time, the damage leads to bronchiectasis, fibrosis, and respiratory failure. In cystic fibrosis, the cycle of mucus plugging, infection, and inflammation continues to worsen over time. Children may experience a persistent cough, poor weight gain, frequent respiratory infections, and difficulty breathing. Treatments include airway clearance therapies, antibiotics, pancreatic enzyme replacement, and in some cases, lung transplantation. Advances in genetic therapy and new medications have improved outcomes and life expectancy for many children. Sudden infant death syndrome, or SIDS, is the sudden and unexplained death of an infant under 1 year of age. Most cases occur during sleep and remain unexplained even after thorough investigation. The risk is lowest during the first month of life, but increases between 2 and 4 months. Since the implementation of the Back to Sleep campaign, the incidence of SIDS has significantly declined. Sudden infant death syndrome typically occurs during sleep and shows a clear seasonal pattern, with more cases reported in colder months. While the exact cause remains unknown, Research suggests that a combination of factors, such as a vulnerable infant, a critical developmental period, and external stressors, may contribute. Many of these infants may have subtle abnormalities in brain regions that control breathing and arousal. Although no single cause has been identified, preventive efforts like placing infants on their backs to sleep have significantly reduced its occurrence.